So I'm going to let Susan speak about the psychosocial evaluation, and then Dr. Tedler and Leslie speak about the living donation. So. And thank you all for your patience. I'm sorry we got so off target, best plan and such.
Hello, everyone. I'm going to keep this very brief, in part because the things that I'm going to say have mostly been said, and in part because I'm speaking mostly to our team who work with these issues every day. So for those who don't know me, I'm Susan Sanders. I'm the outpatient transplant social worker. I'm going to, as I said, go through this briefly. So when people come in, when patients come in and they see our team, I do the psychosocial evaluation. And the things that we look for are how are they functioning, basic functioning? Are they independent in their ADLs? Are they dependent? Do they have a home health aide? Do they have family support? Are they able to communicate? Are they able to be understood? One thing I left off of here, it was just neglect on my part, is do they have a stable home? Are they in a shelter? Are they in a family shelter? We do not accept patients who are in a shelter. We tell them that once they do have stable housing, that we welcome them back. If they're in a family shelter, we get documentation that they're able to return there, and that is okay. Psych issues, no contraindications as long as a patient is in treatment and is compliant with treatment. If someone is not in treatment and needs to be, I will speak with them about it. I'll speak with the team. I'll contact the social worker at the dialysis center, and we decide who will make the referral. Substance abuse, if somebody is actively using substances at the time of evaluation, they are not considered to be a candidate at that time. They must be abstinent for at least 6 months prior to evaluation. If they've stopped and started many times, we will generally refer them to a relapse prevention program. And individual situations are discussed in selection committee. Compliance, we look for demonstrated compliance. There are red flags that pop up, people who say, I don't go to dialysis all the time, I don't like to go on weekends, I like to sleep, I don't take all my medication, I only take the ones I want to, I only take them on some days, I only take certain ones. Those at this point are causes for concern, and we investigate. And social support is huge. Also presenting as red flags are people who say they have no family, have family and are estranged from them, have no friends, unable to say who will help them post-transplant. We also work, we have patients who are blind and come in, they live alone, and we really at this point we bend over backward to document who will support them. We call the family in, we meet with the family to make sure that they are involved before we go ahead and transplant them. And it's done on a case-by-case basis. And I have some case examples. I think I'm going to skip over them. I'll just talk about this patient who presented recently as an example of an issue with social support. A new patient came in at the end of June, single, 67-year-old African-American male Vietnam vet, has a brother who he listed as the emergency contact. However, they have little to do with each other. They speak every now and then. Said he has few friends. I generally ask for 2 contacts. He said, well, I really don't know. I don't have any other friends. He gave me his dialysis physician as the other contact. And I said to him, well, who will help you after your transplant? And he thought, and he said, I don't know. And he said, and if my brother has to be involved, let's just shut this down right now. So that's already raising big concerns over who will help this guy. I mean, right now he's walking around and he's independent, but who will help him? And this will be the subject of a team discussion. I made some slides on 2 failed transplants. I think the team knows who they are. One woman failed after 3 or 4 months, stopped taking her medication, and one man failed after a year, also stopped taking his medication. I think we all know who I'm talking about, but in the interest of time, I'm going to stop. I did go back and look through the notes, though, in preparing for this. Both had good family support, appeared motivated, so it's not always 100% possible to go by the criteria I've set out. These are guidelines, and we do our best. Okay, any questions?
Actually, just one comment, Susan. I think it's really important that people, particularly people on the floor, people who aren't in clinic, realize, these people want something from us. They want a transplant. And it's not that they're being disingenuous, but they put their best foot forward. They come the best way that they can with as much support, and they try to, if you're being on a first date, you don't show anybody the wrong side. So I think you do a terrific job of trying to lead through that. I think the whole team does. It's very difficult, and sometimes it really is a multidisciplinary approach. They'll tell Dr. Tedler or Maxine something different than they tell you. If Victor translates, sometimes they'll tell him something. So it really is, it's very, very difficult. So anybody on the floor who's ever said, well, why did they think it was a good idea to transplant this guy? Now we can't get him home. He has no place to live. We really do screen for these things in depth every time they come for evaluation. But it's an imperfect science, and I think that the team does a great job. So I want to thank you and the rest
sure.
of the team.
Okay. Thank you.